Okay. All right, so we've got a lot that we're going to go over in the meeting today. Enjoy some salty or sweet over there. I do have Breezy from pharmacy here as well. She is taking people out up to 5 at a time to go over the med mixing competency, the sterile med mixing competency. So if you have not had that, when the next group comes back, go ahead and step out and go to the classroom right across the hall and get that checked off if you have not done the sterile med mixing competency. Also, make sure you get signed in as well. No matter how many times I say it, somebody always forgets to sign it. So we do have a couple guests here today. Our first one is Lauren. She's from Iowa Donor Network. And with us kind of reviewing the death process for out at Hiawatha, we figured it'd be a good time for her to come and talk. We try to get them to come every once in a while to meetings to update any new staff and remind us how important their role is in this process. And we haven't had them come for a long time. So I'll leave that to you here, Lauren.
Here I am. I talk really fast. There's a bunch of information on the slides. They'll get sent out. But for everyone's time, I don't talk super slow. If you have questions, stop me. Iowa Donor Network is a nonprofit. We're your only OPO in the state. So anytime you're doing organ or tissue donation in Iowa, you're dealing with us. We're open 24/7, 365. We have offices in Altoona and North Liberty. I'm officed out of North Liberty, and I'm your guys' representative if you have any issues, questions, concerns. We are also now the call center for Iowa Lions Eye Bank. So we used to have to make 2 calls. Now we screen for both of them. I'm here because it's a Medicare regulation that you guys have education every year. And also just to kind of let you know, you need to refer all deaths or imminent deaths that occur. We're going to go over what those look like real quick. Also, just on a little side note, is that we are HIPAA exempt, basically. So anytime we ask for any medical information, you don't have to sign consent or sign release to give it to us. We now have chart access here too, so we shouldn't need quite as much information as maybe we used to. So that's hopefully helpful. How do you become registered? Registration is a big part of donation. It's a first-person consent for us. In Iowa, you can register 3 different ways. You can go online to our online registry. You can say yes when you're at the DOT getting your driver's license. And also, just recently, Logan's Law was passed, and you can be registered when you get a hunting or a fishing license in Iowa, they ask you. Last year, we had about 900 people that were never registered that are registered because of Logan's Law. That was a young boy who was a donor in southern Iowa. So kind of a neat thing Iowa's doing. What is donor designation or registration? It's a legally binding decision. Next of kin cannot change that once time of death has occurred, and it's our responsibility to fulfill that wish for the patient. So there's 2 reasons you would be calling us: imminent death or a cardiac standstill death. So we're going to go over imminent death would be for organ donation first, and then we obviously evaluate for tissue as well. When we're looking at organ donation, these are the organs we're looking at. The time frames up there are just from recovery in the OR to time of transplant, how long those organs are good for. Just a fun little fact. And then we also take liver, lungs, and heart for research if we're not able to place for donation. So why would you refer to us? Your patient must be on a ventilator and meet one of the criteria. So missing 2 or more brainstem reflexes, GCS of 5 or less, plan to extubate for end of life, or family mentions donation. So any one of those and on a ventilator, you guys should be calling us. We're doing a lot more DCD, which is donation after cardiac death. So instead of maybe the old plan where it was pretty common for a family to come in and say we want to withdraw care in the ER, if they're intubated, we would like you to call us first to screen, because we might move forward with donation process and have them admitted. If they're not intubated, don't put a tube in them for donation. That's not like what we're asking. I know that seems common sense, but be surprised at some of the things that happen. And you guys, in order to be timely, which is something that Medicare also regulates, it's 2 to 4 hours of when the patient meets clinical triggers. So if the patient comes into you and they're missing brainstem reflexes and they're intubated, we expect to call within 2 hours, otherwise you get a little red flag when we do your review. So again, I mentioned there's the 2 different pathways: donation after brain death and donation after circulatory death. But basically the important thing is just when those triggers are met to let us come on site and assess that.
I'm going to pause you for just a second. Anybody who hasn't had medication mixing with Breezy, had her check you off on it, go ahead and go across the hall to the classroom and do that now.
So the other way, probably the more common way for you guys to refer to us is after a cardiac standstill and we have a legal time of death. At that point, we're going to screen for tissue and cornea donation. These are the different tissues up here that we can use. This is an example of one little boy who was a tissue donor, and his tissues went to 212 different individuals. So with tissue, if you're a full tissue donor, you can reach up to 250 people, which is kind of just a neat thing to see the spread. What you need to do then is give us a call within 1 hour of death. So that's the difference between time we have imminent and cardiac standstill. It's expected 1 hour of death. And we'll ask you some basic information. If you don't have time to be super busy, just as long as we can get time of death, name, and like a date of birth, we can get in the chart and look. If the chart's not complete, we might call you back later, but that way that gets you off the like 1 hour time frame marker. We do ask for next of kin, funeral home, and any information if you guys have done that. If you haven't, we are going to be speaking to all of them. These are just things that used to be rule outs for us that really aren't rule outs anymore. So a lot of times people are like, well, I didn't refer them because they're an IV drug user and they can't be a donor. That's not accurate for organ. Sometimes it's not accurate for tissue, but it's always best to just give us a call. There's one on here, one new condition in 2020 that's not on here, COVID. That is a rule out for us at this point in time, but you do still have to call and screen with us. They did actually just transplant somebody who had COVID and was recovered out in New York, I believe. So that will continue to change. So always just best practice is give us a call. Funeral home, if you guys know the information, we'll take it, but please make sure you call us first so we can begin our screening process. And definitely don't release the body to the funeral home unless you have heard back from us. We don't want that person getting embalmed and then losing that chance for donation. Medical examiner, we have to get approval from the local medical examiner before we do any donation. We are in contact with them, so I know your practice is to contact the ME. If they've told you yes or no, we're assuming jurisdiction, let us know. Otherwise, we'll call them as well to get a permission. We're pretty lucky. The MEs in Iowa really support donation, so we have a pretty successful rate of doing donation pre or post autopsy. We ask that you cool the body, so get into the cooled morgue, place ice, and then make sure to document that time of cooling. Otherwise, our comm center will call you back and ask that. Just important for some of our tissue processors that we have that documented. Once we have time of death, we have 24 hours to make our incision as far as tissue, as long as appropriate cooling measures have been taken. So that's kind of why that time frame is important.
Is there a time frame after cardiac standstill so the cooling has to happen?
No, we just ask that you do it as soon as possible. But and I don't know the exact equation of how they take that into, but typically it's 24 hours for an incision, and we ask cooling as soon as possible. Okay. If family's here, we don't want you to go in and interrupt. Everybody says very strange. It's like, no, they can have time before you go put ice on them. So, yeah. So if somebody asks you about donation, we go through a training on how to talk about donation. It's a Medicare requirement that you have to go through that training. No one at Mercy Cedar Rapids is trained in that. So we ask that you just say, I'm not sure, I'll contact someone. They'll typically send one of us on site unless we're super busy, and then they'll have one of us call and speak to the family. Even if they're not able to be a donor, we really want to get that information out there correctly. So these are just some of your guys' stats for this year. We get these every quarter and send them out to you. So this is actually the organ referral. You can see one thing we're working on is planned donation. So that would have been someone in the hospital mentioned donation before we could come on site and assess. Sometimes that's appropriate. I'll give the hospital that because family's like, no, I'm done, take it out, and you have to bring up why we're waiting. But we ask that as much as possible that not happen. Oops, sorry. And then this one is tissue, so this one again probably applies to you guys more. You guys can see you had a 96% referral rate, so we did miss a couple of deaths being referred. I can tell you these ones were not from the ER, these ones were from the floor, and they were COVID positive patients. So something new, they knew they were going to be screened out, but we still have to call on them. And then again, we track, like I mentioned, those that are referred within 1 hour. So got a little improvement we can do there. You guys did have, so far in 2010, you've had 10 actual tissue donors. You haven't had any organ donors this year, but last year you had 5, so it kind of ebbs and flows as we go. If you have questions, we have our website. You can always get online resources there. Kind of all of everything I've talked about is up there. Or if you have further, you can always text, call, or email me. And I'm around. I try to get up here every couple of weeks just to see what's going on, so I can always pop down and answer any questions you have. That's it. That's all I got.
Awesome. Thank you, Lauren. So I'm on the Organ and Tissue Donation Committee here at Mercy, and so I do typically see Lauren at least quarterly. So if you have any questions you want me to bring up, if you want me to pass along any information, or if you have any ideas on how we can improve that process, I can surely bring it to Lauren and the committee and see what we can do. So we do have her contact, but thanks for coming.
Yeah.
Thank you for the donations.
Thanks, guys. Have a
Thanks
good day.
for the swag.
And the swag, yeah. I did pass around a few of these. I can make some copies. This is our death process. So this is what the shift supervisors and relief charges and whoever's working out at Hiawatha is following for the death process. I'm not going to go too into depth with it yet because I want to be respectful of Chelsea's time, but we are going to visit this next if you want to just kind of glance over it. But next I'm going to hand the floor over to Chelsea. She is from Lab. She does all of our point of care testing stuff. And we have a new machine called the coaguchek out at Hiawatha. And so, of course, with anything new, we need to learn how to use it. So
first thing I'm going to send around, some of you have already done it. If you have, don't worry about grabbing it. It's just the training sheet for the coaguchek. Second thing I'm going to have everybody grab one is annual competency. Just fill one out and maybe I can pass it through. Here. For you or do you want to okay.
That's the one I did on the first one.
if you've already
Yes,
done
yes.
competency, you don't have to redo it, but
Yep,
not everybody
the
can.
annual one everybody will need with the coaguchek if you've already met with me out at Hiawatha, or we did a couple here too. Don't worry about it.
What's today's date, the 10th?
Today's the 10th.
So we're going to start off with the coaguchek. For those of you that have heard this already, sorry you have to hear it again. But this is our actual coaguchek meter. It's going to do PT INRs, is what we're testing with these. So touch screen, power button. This is the back of the instrument. There is a section for a code chip. So each box of strips comes with 2 vials of test strips and a code chip. That code chip is just hanging out in the box. So careful when you open it. I have opened it up and chucked it across the room before. Without that code chip, these strips will not run in your meter. So you absolutely have to have it. When you open a new box of strips, pull out that old code chip from your instrument, throw it away, put the new one in. If you try to run new strips with the old code chip, it will give you an error code and it will not allow you to run. So strips, similar to your glucose strips, sensitive to humidity, so just leave that lid on as long as possible, pull out the one you need. There's no new outdate on them, so they outdate with that expiration date on the vial. There's no labeling it. To actually run the meter, you're going to hit patient test. Patient ID, yours is going to come up with a numeric keypad. We're entering MRN and patient ID. You're going to get this screen where you're going to insert your strip. Your strips are pretty long and they go about probably a little over halfway into your instrument. Yours is going to beep when it's all the way in. It's going to go on the bottom of your instrument. Just like that. So once your strip is inserted, you hear that beep, you're going to get that hourglass. On the first picture, that's telling you it's matching that lot number of that strip to that code chip that we put in. Once it makes sure that's okay, you'll get a 180-second countdown and a blood drop. That means you go ahead, you prep your patient, and get your blood. Wipe with an alcohol pad, let it dry. Single-use finger stick devices, we're going to test with the first drop of blood. So if you are running an INR and a glucose, go ahead and poke, test with your first drop for the INR, wipe, do glucose with your second. That's fine. On the strips, there is a little section in here that's black. It's where your blood drop's going to go, and there's kind of a semicircle. If you have a good bleeder, just do a drop right in there. If your patient isn't bleeding so well, you can scrape the strip along their finger, that's fine too. So there's no external QC for these meters. It runs QC with every strip. You should get a QC and a check mark right after you put in your blood. It takes about 30 seconds. Once you see that, you know you're gonna get results. And here's our results. We're gonna have an INR, and this will actually be seconds, not percent Q. But if you get an INR of 4 or higher, it's toast. You gotta collect the blue top, send it to lab for a PT INR there. The measurement range for these instruments is 0.8 to 8, but linearity is not good past 4, so we're not even gonna bother with it. If you're already collecting labs for the venipuncture, feel free to use that blood for this as well, so you can do capillary or venous blood, both are fine. Meters are cleaned after each use, just like with glucometers, using sandy wipes, same deal. What questions do you have for me on that one? I went through it kind of fast, but I think I hit all your questions on that sheet. Yeah.
Question, I don't know if this had ever come up, but is arterial blood okay?
It is not.
No, okay.
No. Venous capillary only.
Venous capillary.
Did you say that you have to put the results into Epic?
Yes, you do. So we're gonna order a point of care INR, and it's gonna be entered at just like you're an HCG.
I'm gonna pass, I forgot to pass these around. Here is the strips for it. Take a look at them, they're a little bit different than the ones for the coaguchek. The blood actually goes in this center part here, so I will pass those around. Or do you wanna go through the test or no?
Yeah, sure.
Okay. So we can go through the answers on the quiz here. Thank you. I mean, just let's get these people in the room so they can do it too here.
Can I steal one from you?
Yes, you can.
I'll have these memorized yet.
Feel like the new guy?
Yeah,
I feel like the new guy.
All right, guys, we're gonna go through the answers on this quiz. So,
All right.
to write them down.
So starting with question 1, what is entered for patient ID? It's gonna be MRN. Question 2 is true. Question 3 is true. Question 4, you receive an INR of greater than 4, you're gonna collect a blue top, send to lab. Quality control is run with each test. Meters are cleaned after each use, and use sandy wipes. Alright, go ahead and sign the bottom of those. The second sheet that I sent around, I'm just going to need you to fill out that top line where it says employee name, badge number, and date. And then either on the back of your sheet or on the second page, there is a signature, initial, and date at the very bottom.
We put today's date?
All right, thank you, Chelsea. So for those of you that came in late, I want you to complete the quiz here so that we have all of that paperwork from the meeting here done. She did go through a PowerPoint, but this is all being recorded, so you'll be able to look at that as well. And I'll send out the PowerPoint from both Chelsea and Lauren with the Iowa Donor Network so everybody can review that. So, anybody have any more questions for her before I let her take off?
And I will,
You want to?
I'll
Yes, if
take
you
all
want to
those
pass
sheets.
all of the sheets, the quizzes, and the annual competencies to the left and then forward.
Preferably in separate stacks.
Yes, preferably in separate stacks.
Oh.
We can fix it if you already did it, but it does help things go quicker.
Are you gonna have me watch this?
I can, and then I took this second test. Perfect. Okay. Good deal. Thank you. I figured that'd be the best way to do it.
Yeah. I'll send them on over whenever they're done.
All right. I'm going to keep talking so we can get through all of the stuff today. So I passed around a few of these. I know there's not copies left for everyone. But if you could share them to get an idea of what I'm talking about as we go through it. So this is in our charge book and our relief charge book. It's in the death book. It's out at Hiawatha and here. This is the process that our charge nurses and our staff out at Hiawatha are to follow if there is a death out there. I did start to retype this to try and make it a little more user-friendly, but as I'm going through it, I realized I wasn't typing anything different than what was already on here. It is pretty self-explanatory if you follow 1 through 12 here. I did have Lauren come from Iowa Donor Network because ideally we would have annual competencies or at least education on that. Hasn't been done for a few years, so she does need to come, but it is a very important part of our process. And I think there's a lot of things people don't know when it comes to the Iowa Donor Network. We do not want to be the ones having the conversation with the family. That is their job. They go through specialty training. There's a lot of misconceptions as far as donation. We don't want to answer a question wrong or say anything incorrectly. So we always have to make that call. We need to make it within an hour and let them have the conversation with the family. Even if you think that they're never going to be able to be an organ donor, just call them, even if they have COVID, she said. We are doing a lot more cardiac standstill deaths, so if it is something that somebody wants to pull a tube in the ER and let the person pass, we should be now contacting the Iowa Donor Network with those patients as well. So they get to have that conversation. They also work now with Iowa Lions iBank. We used to have to make separate calls to both places, but they communicate with them. So if we call the Iowa Donor Network, they call the iBank and they share information. For those of you that weren't here, it is not a HIPAA violation. We don't have to have the family sign anything, and they actually have access to Epic. So even if we have 1 second to make a phone call and say, hey, we just had a death, I don't have time to give you all the information right now, they can at least go into the chart and start looking for it themselves. So a little easier on you. It's not like we aren't busy or anything. So make the call within that first hour, even if it's just to say, hey, this happened, here's the name and MRN. We also make a call to the medical examiner. They also work closely with the Iowa Donor Network as well. So even if we're calling both, they're still calling and talking to each other as well. So I just wanted you guys to be aware that the process is written out for you. There is a lot of documentation and it's very detailed, which I'm going to show you where to find that. The biggest thing is, where do I find this information? So I'm going to show you the 2 places for death here. Let's just pick one here. Okay, so if you have a death, there is documentation, and sorry, this screen is really tiny, so I have to keep expanding it and unexpanding it. Down here at the bottom under this general restraint section, you have a post-mortem checklist. This is one piece of documentation that you will need to complete. There is a lot of detail on that. I'm not going to tell you, it's not a pain in the rear filling it out, and there's not a lot of detail, but this is where it is. Then, anytime you take the body, so if you take them to the morgue, or if the mortuary comes straight to the ER and takes the body, we need to send copies of any paperwork that we're completing with the body. This is not easy to print out from here, so to print out the Epic documentation, if you go to this show reports at the bottom and type in post-mortem, anything you documented there is right there, and you can right click and hit print. So that's how you would print your Epic documentation. There's another piece of documentation with death. So when you have a name highlighted,
What are you printing that for?
and it has to go with the body. So if they go to the morgue, that documentation needs to go with them. If they go straight to the mortuary, it goes with them there as well. The other piece of documentation that you need, if you have the name highlighted, we have this box up here that says print forms. They'll eventually come up here, and I'm going to expand it this way. So you're going to find a couple different things here. Right now we're talking about the death process, so I'm going to show you the death packet. If you click that, this is where you'll find that. Here is the report of death, the organ donation checklist. This is a lot of good information to have and complete when you call Iowa Donor Network or the ME. It's kind of like getting all of your ducks in a row before you make that call. So this is kind of your checklist or guide. What information do I need to have? And then here's consent for embalming and or autopsy. There. So there's the death paperwork. 2 places in the Epic chart and under print forms is where you're going to find those. When there is a death, you should be going with the physician to talk to the family so that you're all on the same page, and you can take the packet with you to get what information that you need from the family. I mean, be respectful of their grieving and their time, please. But they should also know that Iowa Donor Network is going to be calling them. I'm sure you will get some people who will be like, oh no, we're not interested in that. And I would just say it's a regulation of the state that they call you. You can give them what information that you want to or don't want to, but you should be expecting a call from them. It is a regulation. So it's not us telling them that we want your organs if they were going to call you. It's just the expectation. So that's the death process. I did retype the transfer process to make it a little more pertinent to Hiawatha and a little more updated. So I will pass these around again. You may have to share a couple of these, but nobody keeps this stuff after the meeting anyway. So this is also out at Hiawatha, and it breaks it down into what needs to be printed and what needs to be documented in Epic. The documentation, you'll notice here in the same spot is the transfer packet. So when I bring that up, I get important pieces here. Okay, so there is this transfer form. Let me clarify quick. Transfer and transport are 2 different things. Again, we are not having to fill all this out when we're bringing them from Hiawatha to here. This is when they're being transferred to the University of Iowa or St. Luke's for like neurosurge, okay? We're not transferring people from our facility to our facility. Does that make sense? Okay. This form that's automatically built, that's everybody.
Good.
Thank you.
Thank you.
Yes. This form that's automatically built into this packet is for air and ambulance. I was initially told that Hiawatha will accept this, but someone just told me yesterday that they brought out new transfer forms out there. So if it's Hiawatha transferring, then you'll use one of those forms. They're printed out and already out there ready to go. There will be cases that you may not know who's going to show up, whether it be Hiawatha or area. For instance, if we have to transfer a patient to the University of Iowa, we call dispatch, which you'll notice at the bottom of this form now, it's no longer 911. They decided they want us to call this number instead.
That was a really fun day.
So, this is the number that we call, and then they're going to contact Hiawatha. If Hiawatha can take them to the university, then they're going to take them. But if they can't, then area ambulance is going to show up. And we may not know that until they get there. So if they want a different form, they're going to have to wait a second for us to fill it out, I guess. So, I wish we had a universal form, and I don't know if there's any way we can get that, but we'll find out here. And then here's the physician transfer record. So you'll find documentation under that print forms section. The other place you're going to find documentation is in the chart. Oh, I double clicked that. So when you go, oh, this is where the screen gets tiny here. Okay. If you go to the transfer tab here, you get all kinds of documentation on the left-hand side, right here. So you get your transport request, transfer checklists. Again, it's just a lot of documentation, which shouldn't be anything new to any of us. This transfer request, ideally you'll fill this out when you call for transfer because you're going to get that information as you're talking to them, okay? Here's the transfer checklist. Again, a lot of information. EMTALA transfer documentation, and then this is the stuff we always fill out: the departure condition, patient care handoff, belongings. Okay. Now, it also asks you to print off the transfer summary, and patient care timeline. So if the name's highlighted, you click on this show report here. Here's my timeline. If it's not keyed in up there for you, you can just type in timeline. Granted, there's not much there on the patient that I picked, but you right click it and print. The other one, if you type in EMTALA, here is the report that's asking for. So there's where all of your forms are located for both of those processes. Yes, Larissa?
So the ambulance is also like a face sheet
Oh yes, thank you.
as well?
I think I have that on the top, I just forgot to show you. So face sheet is also right here. There you go. Just type in face sheet.
And transports, they,
Also-
Hiawatha is also requiring that certificate of need sheet to be filled out by the physician. It's
Okay.
not legal, but Hiawatha wants it specifically.
Okay, so not a legal form of documentation, but Hiawatha is requesting that we fill out the physician transport form.
PCS.
PCS
It is
Physician
in the transfer
certification.
packet.
for Medicare.
So it's in this print form. And actually, it's probably the printed out Hiawatha copy, so you don't even have to print it off yourself.
I've had some Hiawatha crews also request like a brief summary of their visit with us, just because they're assuming care for that time. So they want like a med list for their report, their allergies. And
If you
like,
print
what
off
we've
that,
done. So yeah, just so people know
The
that like,
timeline.
yeah,
Yeah.
or the EMTALA, that stuff should all be in those, so.
Yeah.
I mean, if you want to be extra prepared, just print it all off anyway, but,
So if they're taking a body from there to here, why would we need that if it's just an inter-hospital transfer?
so,
That's their
this is transfer for any patient.
Right.
So, if if it's a body, we're discharging them out of the computer before they leave Hiawatha, okay? And it's the same as what we do to discharge a patient now. We will go to discharge. Oh, sorry. I skipped a step here. Oh, man.
Oh.
No, I'm never gonna get out of there. Okay, so if you go to the discharge tab under their name, you know how it says like, they walked, they went on by wheelchair, you have all of those options. One of the options is expired. So if you click expired, it drops down a few more options, and that's how you discharge them out of the computer. Same way we do now, you just hit the expired option. And yes, we are discharging them even though they're going in an ambulance here because they're going straight to the morgue. So we don't need them in Epic anymore. Make sense? It is going to be a clunky process until you have to walk through it. You're always welcome to log into the playground. There's an Epic training folder on every desktop. You can go into the playground and you can play around with all of those tabs that I just showed you. You can always call charge nurse here if you have any questions as well. They're here 24/7, so you've got that in your back pocket as well. It's a new process, just like a lot of things that we're doing right now. We learn new things about what forms they want and what forms they don't want as we go along, so good deal. All right, so if you guys don't want those pieces of paper, pass them to the left and forward, and you don't have to separate them all. Oh,
These will be out there, correct?
sorry. Yes, those are already out there.
Keep them
If you want
separate
to
if you
keep one
can.
for your own reference, go right ahead.
Don't do that to me.
I got all kinds of papers for you today, so that's why I'm having you pass them and go as we're talking. I'm going to pass a couple more around here. CJ?
Specifically asking.
He's ruining my meeting recording. Thank you. Okay, so blood double checks. We've always been taught that there's supposed to be 2 RNs checking that blood at the bedside. Our policy is actually written very open-endedly for this purpose because there's going to be situations like Hiawatha where we don't have 2 RNs to check the blood. So we are allowing paramedics to do it. Out in Hiawatha for sure, if you get in a pinch here in the main ED, we will allow them to double check here. So I'm not going to walk through the entire blood administration policies and protocol, but we are walking through the double check because the RN still needs to be the one setting up, administering the blood and all of that. So I passed around a couple of forms here. I should have kept one for myself. I'll wait until it gets back up here. So when you know, I'm going to start with the process here at the main ER because it's only easier as you get to Hiawatha. Can I take one of these? Thank you. Okay. So here at the main ER, when we know we're ready for our blood and our blood is ready, we have everything all set up, the nurse is going to print off it's a packet of forms, really. It has the consent, it has information for the patient, and then it has this request to issue the blood, okay? This form, in more or less words, is a lot of back and forth and back and forth and back and forth. So when we're ready for the blood, we're going to take two people, either two nurses or a nurse and a medic, to the bedside, and we are going to place the blue band sticker, where it says place blue band sticker here, okay? You can peel one off the blue band bracelet. If there's none left, which has happened before, you can write it on there as well. You are comparing the patient's chart to their bracelet to the information on the top of this sheet, okay? Once you have verified that information, you're going to say who double checked it. Then you're going to take it to the tube system. You're going to say the tube station number, which if you forget it is written on our tube station, and who the RN is that's requesting the blood. You send this over to blood bank. They're going to do all their fun stuff on their end, fill out their section here, and then they're going to send the blood back with this form. The tube system's going to beep, and it will not drop the blood until someone actually goes in and punches in a code. That's because that blood has to be started within a half hour of it getting here, and if nobody picks it up from the tube station for a half hour, it's just going to go back to lab so that they can get it back refrigerated and it's not garbage after that. So when you get it in the tube station, you see this patient care area confirmation, received by, and what time. And then the bottom is just for blood bank use only. So once you fill out this patient care area confirmation, you send this back to the blood bank. Then you're done with this form until you need a second unit. Then you get to do it again. When the blood gets here, you take it. The blood bags look like this. I'll pass this around. There's two labels. There's a label affixed to the front of the actual bag, and there's a label zip tied, I guess for lack of better words. I don't know the name of those little plastic things to the front as well. You're taking your two people to the bedside. You are pulling up the patient's chart. If you pull up the actual lab, it has the unit number listed in there as well. You're comparing all the same information as the top of that, and you're comparing the two labels. To the patient's blood type, you want to look at the expiration date. So you're comparing this label to the patient's chart and their blue band. It's a lot of comparing, okay? That is the process here. It gets easier when you go to Hiawatha because we don't have a blood bank out at Hiawatha. We have emergency units of blood. It's not going to have this label on it at all. It will have a label like this that is just general to the unit of blood. So in that case, you're not going to have a name on the unit of blood to match to the name of the patient's chart, but please check your order for the emergent blood. Verify name and birth date if you can. Sometimes that's not possible. But look at the type of blood. It should be some type of O blood if it's giving emergent. And make sure you're looking at the expiration date. We don't want to be giving expired blood, and that probably could be a possibility. I mean, there's checks in place for them to check expiration dates, but that would probably be one of our bigger risks out there as well. So I'll pass this around. These are just examples. You can see there's no patient information on the label that's on the bag because that is affixed for the blood identification. This is more of the patient label. So I'll pass that around. Any questions on that? The sign off is in Epic. The nurses know where the sign off is on that, and they'll just ask you to enter your credentials once you do that double check. Good? Okay. I'm gonna let you do vehicle extrication so that they don't have to listen to me talk the whole time through. Am I good?
Yeah. Miranda, you want to come help and steal Larissa's chair?
Yeah, can you go fast?
It takes less than 5 minutes.
Yeah, super fast. So what we're gonna do is quote unquote vehicle extrication. You're an EMS provider, or you're a hospital provider. Okay.
Yeah, we don't let you drive.
Yeah. And you are gonna be the family member. So this is just gonna be a super rough, really short, just a quick idea of how we can attempt to get patients out of a vehicle. So many times we have an unresponsive person in a vehicle, somebody in a vehicle that's not breathing. And we're like, if they're not tiny grandma who we just grab and pick up, sometimes we kind of don't know where to begin. So again, this is just an idea to put in your mind where we can start on getting these people out of vehicles. So kind of at first starts with our registration. Whenever we're broadcasting, can I get help getting a patient out of a vehicle? If it is somebody who is unresponsive, not breathing, things like that, we should probably also say those things. I need help getting a patient out of a vehicle. They're unresponsive, they're not breathing. So us in the back should think, I need to bring a backboard and I need to bring a bed. That way we're not going out with a wheelchair and thinking, what am I gonna do now? So kind of starts with the registration and then the equipment that we're gonna bring out. Again, kind of quick and dirty. We're gonna scoot, sorry, just so we have room. So Bree is our patient who is in the front or the back passenger seat. What we're gonna do is we are going to enter in through the driver's side and we are gonna tilt Bree or the patient to our left side. Be careful we're not putting our feet on gas pedals with vehicles that are turned on, things like that. So just be careful where you are. We're gonna tilt the patient. We're gonna put the backboard underneath their backside as far as we can. At that point, we have the bed underneath this backboard. Might need to be a little bit like this if it's a taller bed, just kind of however it works. At that point, again, at this point, we're just trying to get the person out of the vehicle, so we're not necessarily thinking about C-spine, things like that. Thank you, Kelly. We're gonna work on a count of 3. We're gonna swing the legs up, 1, 2, 3. And then 3, we're gonna go all the way down, 1, 2, 3. And we would pull her out at that point. Could take multiple staff members to do this, but again, that is how we can attempt to get patients out of a vehicle. It's not always gonna be perfect, but at least that's something in our minds that we can start thinking about how we get people out. Somebody who's 100 pounds is gonna be different than somebody who's 500 pounds. But that way, save ourselves and save the patient some time. Any questions? Again, that was just quick, easy, dirty. Yes, CJ?
Why would you take them out feet first as opposed to head first?
If you have a console in the middle of the vehicle, you sure could go head first if you're able to swing the legs into the console for some reason.
That's why I started to turn this way. You're like, other way. And I was like, oh,
Yeah.
this way.
In my mind, again, whatever works for you. Sometimes there is a console in the center of a vehicle where you can't turn their legs that direction, so you might have to turn this direction. But if you can go head first, you definitely can as well.
Just
Again,
make sure
this
you
is
have
not-
the bed head first or foot first as well.
Yes, and this isn't, again, if we're concerned about C-spine, be careful, but again, this is just to get the patient out so we can start assessing them. But again, if you can go out head first, you sure can, but if there's a console in the middle of a vehicle, are you gonna be able to move their legs that direction? Any other questions? Okay, again, it's just quick, dirty ideas to think about how to get people out of vehicles. Thank you.
All right. Thank you. All right, so there is a few new points of documentation. Every year we have an annual update with Epic. It is an Epic thing. It's not a Mercy Hospital thing. It's not a choice we get. This is coming, this is happening, and it just went live yesterday. There's a couple things that should be live today, which I will see if I can show you, but now I've got to get out of this chart here and log back in.
If you just hit pen, you have to put the time in, or if you open up 2 other charts, it'll force close that one.
Oh, see, these tricks, you guys are so helpful. Oh, I thought I put it in.
You have to all there.
1, just put a 1.
1 tab, 1 tab.
Okay, I like that trick. All right, so there's a couple new pieces of documentation that are coming. I can pass this around, but you should have all seen or know what a Mallampati score is from taking moderate sedation, okay? Mallampati score is how difficult is this intubation going to be? You get class 1 through class 4. It is a required piece of documentation for moderate sedation. It does fall back on the doctor, but we do have an area to chart it now. When we're starting a moderate sedation, I usually just say, hey doc, what do you have for a Mal-and-Potty score? And then I document it. There was never a place to do that, but there is now. Let me see if it went live in the playground. It was supposed to hit today. It is under your sedation narrator. Look at that, it's there, yay. This is the first one I've been able to actually show people. So, if you click on it, Mal-and-Potty score, 1, 2, 3, or 4. Your doctor's the one assessing it, not you. So, it's not a hard stop, but there is a place to document it now. So, that's good news. Let's see here. Let me get back to the, oh, I love that part. Okay, so any questions on the Mal-and-Potty score? All right. Okay. Pass this around here too now. I told you I have lost paper today. All right, so I know you've heard of this now, but many hadn't before they took the Smart Pump integration classes, which, by the way, thank you for everybody getting to a Smart Pump integration training class. I think we were the only department that had 100% attendance for our planned classes. There's still some departments that have over 25 people not signed up, and they end tomorrow. So I was so happy. We had more excuses than anybody else not to be there, but we were there. And so now they use us as an example and say, well, ED could do it during derecho and COVID, so why can't y'all? So I know it's a bag of chips, but you got salty and sweet over there. Thank you guys for going. It helps things out immensely. So, yes. All right, so during that Smart Pump training, we looked at a couple orders for sedation medications. One of which was propofol, the other was for Versed. This is on other sedation orders, but those were the two good examples. Thanks there, Elizabeth. That I could come up with. If you notice in the administration instructions there, it says to titrate those medications to a RAS score of, one of them is -1, which I'll have to ask Dr. Useful and Dr. Ocken about because I want my patients a little more than drowsy. And the other one I think says -2. So I'll have to ask about those levels. But you are titrating to a RAS score. Well, most of us didn't even know what a RAS score was a few weeks ago. And we definitely didn't have a place to document it. And if we're titrating a medication to that, we should know what it is and we should be documenting it. So it is now under assessments right here, under RAS score. It is literally just this score. This is not a complicated score. You all have it in front of you. It is how drowsy is that patient, okay? Expand it here. So there's your RAS score. Right under the burn assessment rule of 9s. If you come up with a better place of where to put that, or if you think it'd be better placed somewhere else, please let me know. I just told Amanda the best place I could think of to put it offhand. It shouldn't be under the sedation narrator because it's not just for moderate sedation, it's for any sedative medication. So I was trying to figure out where the best place would be, so that's where we came up with short term. So I am always open to suggestions for things like that. Same with other documentation if you have ideas. I shoot Amanda Haggerty emails all the time to come up with better places for things or ideas of things to document. So that is the RAS score. Law enforcement discharge. This is not live yet, but it is likely coming, so I figured now would be a good time to show you guys. There is a lot of verbiage under this yes or no question, which you will see, but honestly, the only thing for you is the yes or no. So don't let the other stuff worry you that this is a whole process change. So when we get a patient in via law enforcement, a forensic patient, security, it's broadcasted that there's a forensic patient, and security comes down and talks to them. They like to touch base with them. We want to know anytime there's any kind of weapons or guns on premises. And if the patient's going to be admitted, I don't know if you knew this, but they actually have a conversation with them that if they're admitted, they have a form that they fill out. And so all of that stuff that's written there under that law enforcement discharge is actually already happening. Our security is doing that form. However, if the patient's getting admitted, for some reason that information or documentation that the patient came in with law enforcement, because they don't always stay, I guess, with the patient. Sometimes they just want to call when they're being discharged. Well, that information isn't getting relayed, and here we are discharging patients that should be going back to jail. That's kind of a problem. So if we hit this yes or no, I think somebody mentioned yesterday, they talked about the best place to put this would be the admission narrator. And if you disagree, let me know, but hit the yes or no, and that way this actually filters upstairs, and they see that this person needs to be discharged, or at least a phone call made to the deputies, so that they don't release people that should be going to jail. Does that make sense? I will send out more information once I know that this is going live, or if anything changes beforehand, but I just wanted to bring it up and show you. All it is a yes or no question. It should be easy for us to do. We have enough questions, you probably won't even realize you're clicking it after a week or two. All right, last but not least, my chart sign up. So if you've been to a Mercy Care facility, doctor's office, on your discharge summary, there is a code with information on how to sign up for My Chart. My Chart is a very useful thing. People can look at their lab results, they can communicate with their doctor, they can make appointments, they can actually do video chats with their doctors now. We want more people to sign up for My Chart, okay? It limits the questions, the contacts, the questions we get called in, those types of things. However, if you're anything like me, when I go to the doctor's office, I throw those papers away on my way out the door, or my children color on them in the car, and I never see them again. So when they're like, oh, well, you use that little code on the bottom of your paper, it's long gone. So one thing they started doing in the clinics, and now they are implementing this upstairs, is either on, it would be under the discharge narrator. It's a question. Do you want us to text you My Chart link and sign up code to your phone when we discharge you? It would go to the phone number that they have on file for the patient, and at least for me, I think that would be easier. So many people do everything on their phones nowadays. Okay, I click this link and fill in this code, and here I'm signed up for My Chart. So it's just another thing to help our patients out, and hopefully us in the long run. And Ben actually pointed this out to me, which I never knew this was actually in here. He said we already have that, and I said I don't think we do, but if you click this, it doesn't have the text option, so that will be new. And I think it'll be under discharge narrator when it goes live, but you can actually send an email. And it does print off our discharge instructions already anyway. But like I said, most people don't keep those. Half the people leave them in the room when we discharge them. So that is there now.
Will it still ask you if they already are signed up for My Chart? And if they are already signed up and they do that, will it affect their current chart or anything like that?
I doubt it will not ask you. Like, I think it's going to ask you every time. But like when your discharge instructions print out now, if you are already registered, it says, we see you are already registered. So I'm guessing it would be something like that. But I'm not 100% sure. I can ask that question to Shelly Height. So Shelly Height and Amanda Haggerty, the two epic people for inpatient and ED, are working together on how they're going to make this work for the ED, but it is something that's probably coming. So I want you to be aware of that.
Question on that too. Lately, I've had patients calling into the room and being like, it says I'm supposed to be an x-ray right now. Am I supposed to go somewhere on their My Chart?
Oh,
Is
really?
there a way to not push it to their phones immediately?
I'm guessing no,
really
but
stupid.
Yeah,
I'm
I
like,
have people
it
tell me
says
their
I was
results
in-
when I walk in the room.
Yes,
I'm like,
I was an x-ray. It's supposed to be an x-ray
Really?
45 minutes ago.
interesting.
So,
I've never heard that before. Well, I did just get the app, so I'm going to have to check that out. I really hope I'm not in the ER anytime soon, but you never know with my children. So.
Waiting for stuff to come back, and they're like, "Oh no, it's all back."
Like if you had like a,
Well, you know, I would. My response would be once it comes back to us and the physician gets a chance to look at it and assess everything in your chart.
so does our like Amanda, she does the My Chart part too?
She doesn't do the My Chart part, but she does everything to get it into Epic. So she works with the people who do My Chart. My Chart is a separate.
And like you can't see anything from that visit until you're discharged.
I'm gonna have to ask about that. I don't know, but I have never heard this before, so that's good information to hear.
did have a delay. Maybe they
Could we
improved
also
it so
put
it
it
doesn't
like
like
last known height
office
somewhere
visit,
in
it
Epic?
does.
Last known
What?
height.
Yes, because we have to chart a height. Sometimes the pharmacy will call your patients over at imaging, and they're like, "How tall is your patient?" And I'm like,
Because there's a last known weight,
There is a
but
last
no
known
last known height.
"Yeah."
I thought they
it forces
took that
height
out.
on stuff. Some stuff forces height and stuff like that, and it doesn't
Okay.
put it in anything.
I wrote those down. I will check on those. After these meetings are wrapped up for the week, this is the last one, I'm going to be sending out the Iowa Donor Network PowerPoint, Chelsea's coaguchek PowerPoint, and then as I hear of these updates for the law enforcement discharge and the My Chart, and as I ask the questions and get those back, I will keep filtering that information out to you as well. So, and if you come across any other questions or concerns, as always, you know, let myself, Elizabeth, Kelly, Eric know, and we can figure that out. All right, so a lot of updates coming with that. As far as I've noticed, and the updates are done in here, so I haven't noticed any other changes, but I'm sure someday I'll come across something that looks different.
Track board's
Go to
different.
the manager, the next tab over, it's aligned different. Oh, and triage.
I never went into the
When you hit the
manager.
triage tab, that is all sorts of different looking buttons.
Now when they have laceration, it gives you like the body too, and it shows up on the body where
We've
you.
had that, actually. Most people
Oh,
just
yeah,
didn't know where to
the
find
ID
it.
Well, I mean, it's popping up automatically.
Yeah, it's instead of picking the buttons, you pick your body part.
Well, this isn't that different.
When you have it on a big screen, you can kind of tell, because
Oh,
it's, yeah,
okay.
that waiting in and out, it's like stretched out. And if you like open a patient and then try to triage them, those buttons are.
Okay, so there are a lot more changes. I just didn't see them in Smart Pump training. So what CJ was talking about, the physical diagram, has actually always been up here. This
Isn't.
you can use.
It's like if you're charting a wound,
Well, let's go into it here.
It does it for IVs now too, because I had like
Go to-
I was charting in an
go to, like,
IV that
your-
nested.
go to
So
skin.
it brought up like a little body, and I was like,
go to your skin assessment.
on like the AC, and I was like, so fancy.
Skin, then click on wound.
You can use still
Wound present push. Laceration. Wound, click on that one. That's where it was popping up.
Okay.
Like if you
Maybe
just
it's
went to
just
that
because it's the
pop-up.
playground, but so there are some changes. I just haven't seen them yet. So hopefully those are helpful changes. Actually, they sound like good
The
ones.
IV one's been okay, it's not the same diagram, it's like a highlightable body. Like
They've
you-
actually had that for inpatients, so I don't.
Oh, yeah.
I'm sure it's new for us, but
I haven't had any wonky IV sites yet, but it
Okay.
does seem to go pretty good.
so they sound like good updates. Hopefully, so good. Something positive. All right. Two more things.
What's triage? What's the triage difference?
The buttons look different in there, and like,
I don't know if they
there's
will
some
in this training environment.
added or removed. There's a few more things, and then they're like lined up different. They're not centered justified. They're more like left justified down this left side instead of.
Okay, so it looks the same
It's
on
just
here.
different.
So you'll have to. This is the playground, so it's supposed to be the same as the main environment, but there are some differences
It's
in
on the
here.
triage acuity one, because that's where I first saw it. That's where it was different. Yeah.
Okay, so there's a
It's a
couple.
little,
It just looks a little
rival dog.
aesthetically different.
Are you posting this on your YouTube?
Yes, I am. So let's hope any non-mercy people don't find my YouTube channel and start looking at this stuff because they will think we don't.
They'd be
take
scared
it
of sharks.
seriously. They need some kind of blood. Oh, we have a blood bag. We can make some blood.
let's rip it open. It's.
All right, so again, I'm going to pass around another piece of paper. Our COVID screening that we have right now. We are getting more and more people hired, the hospital is, for those screening positions. Hopefully that is taking some of the burden off. I know them getting their breaks has been a topic for discussion, especially when we aren't getting ours, but we'll do our best. It is getting cold outside. Hopefully we're just in like our fake fall and then back to second summer and then back to fall. But it's getting cold outside. We're not gonna wanna walk these patients outside through the winter. At least I don't really want to do that. So our screening process at the door is more or less the same. The biggest difference is, and I just passed around that algorithm, if a person screens positive, where they would now say, can someone meet this patient outside and bring them back to a room, they're going to mask the patient and someone is going to go out to get them, and as long as they are masked, they will take them the shortest distance and you may walk them through the waiting room and back to the room through a hallway. Yes, CJ?
we had a little incident with that yesterday.
Okay.
Because Terrence had sent out that email that said
Yes.
to do that. However, the registration people never got that. So they were questioning when we did that, why we were doing it, that they need, because they were bringing people around and meeting people at the garage. I said, no, we're
Okay.
not doing that anymore. So if that,
I will
and they
relay
asked me
that
to
to them.
forward that, but I didn't want to forward our email to them without
We'll give them the
that
information.
being okay. So they need that information.
If they don't, they will.
It's on the wall.
The screeners actually now take a class before, when they're hired, they take a screening class, that's like an hour long. So they are going over this process in that class, and they should all be on the same page. But it is a job title that they are specifically hiring for. But just the best advice I can give you with these screeners is keep good communication with them. They were told that they are gonna get their breaks and we're breaking them. That's all fine and dandy and great when we can do that. But if you can't, just relay that to them that you can. Open communication is the best recommendation, yes.
So if we're having someone sent from like their doctor's office or urgent care, you know, front ranch gets a sheet saying that they're coming, do the screeners sitting out front have any notification of that? Because sometimes there's like, you know, they're coming strictly to us.
They still get asked, stopped and asked those questions, and they still should screen positive at that point, so. Does that?
In triage, and they got back to a room, and it was like, you know, they ended up getting swabbed for COVID, and they had like, you know.
How did they make it past the screeners out front? Okay.
So I'm just wondering if they had any idea, and it wasn't, I mean, he's negative, it was like not a real ISO concern,
But still, it
I
could have
just
been.
didn't know if they had any like warning that those like people are, hey, we're gonna be getting someone from the, you know, urgent care doctor's office, potential ISO or.
I've ended up seeing several patients in triage that were just positive within the first few questions. And I said, did you tell them that up front? And the patient's like, well, no, then they treat you all weird if they think you have a cough or you've been exposed. One lady worked at Whirlpool and like,
Oh gosh,
she
okay.
had COVID and she's like, well, I didn't want to tell them that. I was
That's a
like,
big thing
thanks,
too.
appreciate it.
Lately, I've been having to do both screener and front reg, and so like, I'll like walk on like screener, and I'm like, oh, do you have a coffee or first breath, like go through the whole thing, and then I say no to all of it. So when I take them through to then register them, they're like, well, actually, I've been having diarrhea for the past 3 weeks, and I have this cough now, and I'm like, dude, I'm the same person right now.
I know.
You
it's
can
the
just
same-
do the best,
yes.
you know.
You do the best you can with what we're given.
And as long as they're masked and you're masked,
You're good. Well, that's what I'm saying, like, what's the point of even having them like?
Because it's what we're doing, it's the best practice, it's going to catch more people than not, hopefully, but it's like STDs. They're not telling us that we're here for STDs, they're telling us they're here for abdominal pain or something else.
Same reason we're taking their temperature when it's
So-
45 degrees on this reading 70.
We're doing the best we can.
86 was this morning, if you're wondering.
We're doing the best we can
We're
with
doing
this,
something.
the reality that we're given here, okay? You know, sometimes we don't have a better option, and if you have better suggestions, send them on our way, and we can pass that along and hopefully improve our processes. This is a new thing. Nobody expected COVID or HO, any of those things, so we got to start from scratch. I don't think ever in history before have we had to come up with all these policies, protocols, processes in such a short amount of time with so many revisions. So we're doing a good job with that. You got to hand it with what we're given and the lack of research and everything. We're doing a damn good job. So
I have one more question.
yeah.
So what happens, do we have a plan or do we know what we're gonna do when we start getting the flu? So, like,
Good
you still
question.
have
This
to
came
be-
up
You
yesterday.
still have to be off that amount of time if you come in with a fever. If you show up for work and you have a fever, it ends up, you know,
Well,
whether you get flu swabbed or not.
currently, our process is not you're off for 2 weeks if you have flu-like symptoms. Our process is if you have any of those types of symptoms, you are directed to employee health. They screen you and see if their screening necessarily means you need to be tested. If it is, then you will be off to be tested, and the results are coming back within 24 to 48 hours for the most part, with the exception of holidays and some weekends. And then you're either back to work or not within like 2 days.
So once you have a negative test, you get to come
Yes,
back.
then you come back, even if you still have the symptoms. If you choose to stay off because of your symptoms, that's you calling in sick.
Right.
You will get paid by Mercy if it is them telling you to stay off because you're being screened. But if it's past that point, no, they're not paying you, you're using your paid leave. So, good, yes, I'm glad we.
I was worried, I was like, if I get that vote.
No, nobody is off just automatically for 14 days.
That's, okay. Makes
So,
sense.
some people in the community have a hard time believing that even if you have a known exposure, it doesn't mean you're off for 2 days. We don't even screen right now unless you show symptoms. We are all wearing some sort of PPE while we're here, and we're all responsible adults and hopefully know when we are sick or not. So, and there it comes to us, it is hard even as employees to answer those questions truthfully, especially when you got allergies and trees down and here's flu season. It is going to be difficult when flu season hits and we have patients coming in and flu symptoms are the same as COVID symptoms.
Well, if you look at your screening questions, they have to answer 2 now on that sheet in order for them to be sent back for COVID. So if they answer, yes, I have a cough, and then they have a fever, then they get called back.
It's like
to COVID.
SIRS, you have to meet 2+ of the criteria.
Yeah.
So that is another new thing. That's good to bring up. All right, any questions on that? All right, I'm gonna hand over the floor to whoever wants to talk, Kelly or Elizabeth, on Laborworkx stuff.
Okay, couple things on Laborworkx.
You get to come up here so you're not talking
I'm on the
behind.
camera now.
Don't let
Some
CJ
sharp.
touch it.
Couple things on Laborworkx, because I'm the fun person who gets to play with that now. Make sure whenever we're doing no lunches, make sure, one, that that's something that's approved from the shift supervisors. So on their charge report, it's going to say these people were approved for no lunch or whatnot. So whenever that does happen, make sure that we are, whenever we're clocking out, that is when we're using that special code no lunch. We're not adding a clocking, we're not clocking in no lunch, like I know today is gonna be awful, so I'm just gonna go ahead and clock in as no lunch.
Because people do that.
Yes, they do. So make sure we're just using a special code when we're clocking out, that's the no lunch. The other codes that we do clock in and clock out are such as right now, meetings where clock in is meeting, clock out is meeting. When nurses for their next schedule and techs for this current schedule and the next schedule, all of those mandatory extra hours, when you clock in, it's IP2 for those extra shifts, clock out IP2 for those extra shifts. So for no lunch, it's just when you clock out. For those other ones, when you're doing classes, meetings, IP2, that's in and out. Make sure we're also using the badge reader that's in front of trauma. I know occasionally you'll have class over in Hall of Pride, things like that, but we should be trying to use the one that we have right outside of lab. And we also shouldn't be getting in the habit of using ad clockings. We should be using that quick badge if we're using the computer to clock in versus those physical badge readers. Make sure we're doing the quick badge. And then you can always go back, because I know the quick badge doesn't immediately offer you those special codes, so the preceptor pay, the incentive pay, things like that. You can go on the TCS tab, that's where you can enter those in at, so the time card screen. So that's where you enter those in. Any questions in regards to no lunches or any of those? We're only clocking in at 58 is when we're allowed to clock in, and then we can clock in until 03. So we have a 5-minute window. So if I'm scheduled at 7 a.m., I can clock in at 6:58, and then once it hits 7:04, that's when I'm considered tardy. There's an occasion, there's several occasions, it's super busy, I got here 10 minutes early, charge nurse is gonna say, hey Kaylee, any way you can go grab that call back that's been waiting? Charge will then write on their charge report, Kaylee Evans clocked in, okay to clock in early. So make sure that we are following those, procedures.
Did you say the ad clocking versus the quick badge? Okay.
Yep. Any questions in regards to Laborworkx? Already in the last 2 days, it's already gotten much better.
Is that also for staying late? Like if you stayed and your half hour hits and it's nuts and your
Charge nurse has been, Brooklyn stayed late this morning. So on the charger, it just said Brooklyn stayed till 0500.
They should also be aware if you don't have lunch. If you're clocking out no lunch, those should be in the charge report too. So the charge should be aware.
Yeah.
And then we were told yesterday by somebody, now it has, it's supposed to have switched over to, if you're one of the employees that works both here at the main and at Hiawatha ED, when you go to badge in, it asks you, are you clocking into this department? So it should automatically ask you that.
And I've done both so far since that changed. It was right in Hiawatha. It said, are you working in this department? And then the Hiawatha department. And when I came here, it was back to normal.
Okay. Correct. Yeah, because this is like your home department. So just follow those cues that the badge reader asks. A couple of other things. We were talking about charge reports, just a couple of general housekeeping type things that seem to be coming up quite a bit. So just kind of friendly reminders. make sure before we leave for the day, we're checking in with charge before we're ever going. So it's not just like, see ya, gotta go bye. It's, hey, anything you need to go, need me to do before I go. It could be, there are 15 dirty rooms. Can you clean one room before you go? Then they'll say that to everybody. Or there are 10 people that need to go upstairs. Can everybody take one patient up and then you guys are good to go? So whatever, maybe, or it could be, have a great weekend. So just make sure we're checking out with charge before everybody goes. So that way it's not a mass exodus and then what did we just get dumped with? So checking out with charge, making sure whenever we're transporting patients upstairs, when we're bringing those beds back, make sure we're just taking that extra minute or two to clean those rooms. So we're not just dumping those beds and monitors in those rooms. So just take that extra minute or so. And then when we're out in Hiawatha, truly my hand cramps after I'm writing 30 shifts, 60 sheets worth of a month of dailies. So I have all the techs just in 12-hour shifts. That does not mean you have to be out in registration for 12 hours and a tech in the back for 12 hours. Check in with your buddies, flip-flop halfway through, flip-flop after 3 hours. Just checking on each other. That way everybody, nobody's getting stuck somewhere. Everybody's a team. So just check on your buddies. Any questions in regard to that stuff? Again, just housekeeping stuff. Okay. Okay. I have a couple. Again, I've only taken over the employee of the month and above and beyond for this month. So all I have is for August. And truthfully, we forgot until today. So everybody go tell your friends who were at the last 2 meetings. We have a couple of different emails that we got. Here's one that we got sent. Just wanted to give a kudos to Mark Sherman. He was in Hiawatha tonight and he ran labs here to the main and saw how busy we were with the patients in dirty rooms. He cleaned about 5 rooms really quick before he headed back to Hiawatha. It was super appreciative that he jumped right in without even being asked to help out. So Mark helped out doing that.
And then he caught a lot of flack for it when he got back. We're like, where are your brains? Like, they were busy. I cleaned rooms. Like, oh, sure.
Right.
Look at now.
Stop that talking about.
Right. Then we have another one. It looks like Mackenzie Grodelution and Mariah Ehrman RN were great, and they went above and beyond with my care. As stated previously, Mackenzie was outstanding with my care. She took time to explain the things and listen to my requests and concerns. My husband came in with me to the ED, and he was very impressed with the time, courtesy we were extended, and the care provided to me. He told numerous times, and still a week later tells me how impressed he was with the care I received and how caring the nurse and provider were during this visit. My care in the ED from start to finish was with great staff and a provider were on the top of my care and explained everything from beginning to end. Sorry, it's kind of pieced bit by bit, but so Ryan and Mackenzie. And then another one we had, I don't have the email printed out, but big kudos to Caitlin Accord. She is not specifically in our department. She is out in front registration, but it has been noticed that she's been going above and beyond in the last couple months. She has been found cleaning dirty rooms, helping us out when she knows that we are swamped and she's probably busy as well. She has been noticing that ambulances are being sent to rooms that are dirty, so she'll go ahead and clean them really fast. Like, here you go, it's ready for you now. So again, she's going above and beyond. That's definitely not part of her job. So after we got together, we are going to give Caitlin Accord the Above and Beyond Award, and Mark Sherman is going to get the Employee of the Month for August. So make sure for the new staff, this is Michelle Williams. She's a new tech for us. And then we have Jessica Heald. So these are 2 new staff
There's
our
Michelle.
Group. Everybody.
And there's Jessica back there.
They can send us emails.
Everybody else say hi.
If you ever have any type of good experience with a coworker, a staff member, you can send us nominations about these good interactions. And then what these actually are you're going to get a $125 check and a cool pin. So everybody likes cash, let's be real. So
nominate people.
Yeah.
I think we're forgetting about it. Everybody knows our reality. We're super crazy. We're shorthanded. We are doing our best to hire and maintain the people that we're hiring. So remember what these people are going through right now. They're being hired during 2 crises at the same time, and everybody's morale is kind of down. So we're all trying to do our best to really take these people under our wing as a team. It's not one person's job, and give them good training, because if we don't help people learn and stay, they're not going to stay, and then we're going to be in this rut of hiring and training over and over and over. Okay, we've been through this before, and you know, we get back up, but it does take a while, and it's crappy while we're in this spot. I mean, everybody knows that. I don't think anybody's trying to deny that it's a crappy situation, but we've done it before. look at what we've done in the last few weeks with COVID and derecho. I mean, hell, I never could have thought we did the stuff we did during that week of derecho. That was pretty impressive. So you should be proud of yourselves.
So everybody welcome all the new staff, and if you ever see them look lost or like they need a little bit of help, just take them under their wing, because as you know, they might not have a tech preceptor here because a lot of them are at Hiawatha right now. So just kind of keep that in the back of your mind and take them under your wing, okay?
Thank you guys for coming.
Stop.
Hang on, let me try the remote.
Drop.
Did it stop?